Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Grazie per essere con noi oggi sul canale Anesthesia and Perioperative Medicine.
Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria.
आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद.
Okay, so today we are diving deep into one of the coolest and, let's be honest, most challenging procedures we get to manage, the awake craniotomy. We're going to cover the whole thing, soup to nuts. We'll start by looking at the big picture, the patient's entire surgical journey. Then we'll zoom in on our specific protocols, both pre-op and intra-op. After that, we'll talk about what to do when things don't go as planned, managing those complications. And we'll tie it all together at the end with the core brain physiology that explains why we do everything we do.
All right, let's kick things off with the big picture. Before we get into the nitty-gritty or anesthetic plan, we really need to understand what the patient and the surgeon are going through. It gives us the context for everything that follows. So let's start with the most fundamental question.
I mean, you have to wonder, right? Why put everyone, the patient, the surgical team, us, through such a high-stakes, demanding procedure? It really boils down to this incredible balancing act. The surgeon needs to get as much of that tumor out as possible, but without damaging the very parts of the brain that make the patient, well, them.
And the payoff for doing it this way is, honestly, massive. It's all about preserving that patient's quality of life. Think about it. With the patient awake, the surgeon gets instant feedback. They can literally map out the brain's eloquent areas, speech, motor function, in real time. This lets them be way more aggressive with the tumor resection while staying out of critical zones. The result? Fewer neurological deficits after surgery. And there's more. Patients often bounce back faster, their hospital stays are shorter, and they just get back to feeling like themselves again sooner. It's a huge win both for the patient and for the healthcare system.
Okay, now look at this timeline. It's pretty amazing how much work goes into this before the patient even sees the inside of an OR. This is not a procedure you just decide to do on a Tuesday. We're talking weeks of planning, multidisciplinary team meetings, and super specialized imaging like functional MRIs. They might even give the patient this pink drink, 5-ALA, which makes the tumor glow under a special light for the surgeon. So the patient isn't just medically ready, they're also psychologically prepped for this unique experience. For us, knowing all this background is absolutely crucial. It informs every single decision we're about to make.
So the surgery itself plays out like a 3-act drama, and we are the stage managers of consciousness. It's pretty cool when you think about it. Act 1 is asleep. This is where we take over. We provide a deep general anesthetic for all the really stimulating, painful parts, placing the head in pins, making the incision, and actually opening the skull. Then comes Act 2, the main event, awake. This is our big moment. We have to wake the patient up gently so they're calm, comfortable, and cooperative for the most important part, the brain mapping and tumor removal. Finally, Act 3, asleep again. Once the surgeon's done their delicate work, we put the patient back to sleep for a smooth, comfortable close.
And during that awake phase, the patient transforms from being just a patient into an active, vital member of the surgical team. I'm not kidding. They're not just lying there passively. A neuropsychologist is right there with them, guiding them through simple tasks like the ones you see here, naming pictures, wiggling their fingers, reading a few words. And while they're doing that, the surgeon is stimulating different parts of the brain. If the patient suddenly hesitates or can't speak or their hand movement stops, boom, that's immediate, real-time feedback. It's a living map that tells the surgeon, don't cut here. This is exactly why we need them awake. It's incredible. Okay, so now that we've got the lay of the land, let's pivot to our specific domain, the preoperative anesthetic protocol. You know, a successful awake cranio is really won or lost before we even roll into the OR. This is where we lay the foundation.
First things first. Not every patient is a good candidate for this, and our input here is absolutely critical. Yeah, the surgeon determines the surgical indication, but we have a huge say in whether the patient can actually tolerate the procedure from an anesthetic and psychological standpoint. Can they really lie still for hours? Can they handle the anxiety of being awake? Things like a bad cough, morbid obesity, or a known difficult airway can be deal breakers. So while it's a team decision, our voice, our assessment of the patient's cooperation and medical fitness carries a ton of weight.
When it comes to pre-meds, it's all about walking a tightrope. We want the patient to be comfortable and calm, but not so snow that they can't participate in the mapping. So we really lean into non-sedating options. IV acetaminophen is a great start for baseline pain control, and PNV prophylaxis is non-negotiable. Dexamethasone is a star player here because it pulls double duty, helping with brain swelling and preventing nausea. We are super cautious with benzos.
A little bit of midazolam might seem tempting, but it can really mess with the neurocognitive testing, so it's reserved for only the most anxious patients. And we pretty much steer clear of anticholinergics. The last thing an awake patient wants is a painfully dry mouth, not to mention the risk of delirium.
Giving the surgeon a nice, relaxed, slack brain to work with is one of our most important jobs, and that starts before we even get to the OR. We use a multimodal approach here. It starts with something simple, positioning. Just tilting the head up a bit improves venous drainage. Then we bring in the big guns pharmacologically. Dexamethasone helps with edema over time, and we'll often give mannitol right before the craniotomy to osmotically shrink the brain. But intraoperatively, our most dynamic and powerful tool is ventilation. A little bit of controlled hyperventilation causes cerebral vasoconstriction, which literally gives the surgeon more room to work. But you have to be careful. Too much, and you risk ischemia. It's a delicate balance.
Okay, let's get into the heart of it. We're in the operating room. The patient is on the table. Let's talk about our core intraoperative management, the specific techniques we use to navigate those tricky asleep and awake phases. So one of the first big decisions we have to make is our overall anesthetic strategy. Are we going with monitored anesthesia care, the awake, wake, awake technique, where the patient is lightly sedated and breathing on their own the whole time? Or are we going to use the asleep, awake, asleep approach? MAC is great because it means less airway manipulation, but man, it requires a rockstar patient and puts you at a higher risk for airway obstruction. The AAA technique, on the other hand, gives you a secure airway for the painful parts and total control over ventilation. The trade-off is that the transitions, waking them up and putting them back to sleep, are much more complex. The right call really comes down to the patient, the length of the case, and your team's comfort level.
But listen, regardless of whether you choose MAC or AAA, there is one thing that is absolutely non-negotiable. The cornerstone, the foundation of a successful awake craniotomy, is a rock-solid, profound scalp block. You have to remember, the brain itself doesn't feel pain, but everything we have to go through to get there, the scalp, the muscle, the bone, the dura, is incredibly sensitive. Without an excellent block, this procedure is just plain impossible.
And this is how we do it. The goal is a comprehensive block that covers all 6 of these major sensory nerves, essentially numbing the entire scalp from front to back. The classic trick is to use a cocktail of local anesthetics. You mix something fast-acting, like lidocaine, with something long-lasting, like bupivacaine. You get the best of both worlds. Adding epinephrine is also standard practice. It reduces systemic absorption and makes the block last even longer. And some folks will even add adjuncts, like dexamethasone, to really extend that duration. You want this block to be working perfectly for hours.
So the scalp block is the main event, but we can't forget the details. Meticulous local infiltration at key spots is just as important. Before that Mayfield head frame goes on, every pin site needs to be generously infiltrated with local anesthetic, all the way down to the bone. The surgeon will do the same along the planned incision line. And then there's one more critical step. Once the bone flap is off, the dura is exposed, and the dura is very sensitive. The technique here is simple but elegant. You just lay some cottonoid patties soaked in preservative-free lidocaine right on the dura. Let them sit for a few minutes, and that's usually enough to numb it up before the surgeon starts manipulating it.
Okay, so we've planned everything perfectly, but this is anesthesia, right? We always have to be prepared for complications. In an awake craniotomy, our ability to anticipate trouble and react in a calm, systematic way is what ensures a safe outcome.
So let's talk about the big one, the complication that makes everyone's heart skip a beat, an intraoperative seizure, which is usually triggered by the electrical stimulation during mapping. When this happens, there's no time for confusion. Everyone in that room needs to know their job. Having a clear, rehearsed plan is absolutely mandatory.
And here's that plan. Our response has to be lightning fast and perfectly coordinated with the surgeon. Step 1, the surgeon immediately stops stimulating. Step 2, and this is the coolest part, the surgeon irrigates the seizing cortex with ice-cold saline. The thermal shock is often enough to break the seizure right then and there. It's incredibly effective. If that doesn't work, then we step in with pharmacology, a small bolus of propofol or midazolam. All the while, our number one priority is the airway. Maintain patency, give 100% oxygen, and in the rare case that the seizure continues, we have to be ready to pull the plug on the awake part and convert to a general anesthetic.
The airway is our constant obsession, especially if you're doing a MAC technique. Our access to the patient is terrible. They're under drapes, they're in pins, so we have to be hypervigilant. The first signs can be subtle, just a little snoring or a slight dip in the sats. Our response has to be a stepwise escalation. First, turn off the sedatives, give a good jaw thrust. If that's not cutting it, move on to an oral or nasal airway. If things are still going south, you have to be ready to place an LMA or even intubate.
And you need to be communicating clearly with the surgeon the whole time that a conversion to GA might be imminent.
For these other common issues, the key is always to think before you act. Figure out the why before you treat the what. Is the blood pressure high? Well, before you slam in some labetalol, think, could it be pain? Could it be anxiety? Treat that first. Is the patient getting agitated? Before you reach for more propofol, your first thought should always be, could they be hypoxic? Could their CO2 be climbing? Could they be in pain? And seriously, never underestimate the power of just talking to the patient, reassuring them. Sometimes a calm voice and a hand to hold are the best medicine. The theme is consistent. Diagnose, then treat.
All right, for our last section, let's zoom out and connect all of our clinical actions back to the fundamental physiology. Honestly, this is the stuff that separates the button pushers from the true perioperative physicians. Understanding the why is what makes our practice both an art and a science. And it all begins with this, the Monro-Kelly doctrine. The easiest way to think about it is that the skull is a rigid box. It's filled with three things: brain tissue, blood, and cerebrospinal fluid, or CSF. Since the box can't get any bigger, if one of those things increases in volume, like a tumor growing or swelling from edema, something else has to decrease to make room. At first, the body can compensate by pushing out some CSF or venous blood, but once you run out of that wiggle room, any tiny little increase in volume causes a massive, dangerous spike in intracranial pressure. This single concept is the reason we're so obsessed with managing ICP. And that leads us directly to probably the most important formula in all of neuroanesthesia. CPP equals MAP minus ICP. Cerebral perfusion pressure is literally the pressure that's pushing blood and therefore oxygen to the brain. It's the brain's lifeline. And this beautiful, simple equation tells us exactly what our job is. We have two levers to pull. We can support the mean arterial pressure, and we can do everything in our power to lower the intracranial pressure. Our entire anesthetic is designed to optimize this delicate balance. So, how do we actually pull those levers in the OR? Well, our most powerful minute-to-minute tool is our ventilator. PaCO2 is an incredibly potent cerebrovasodilator. If you let the CO2 creep up, the brain's blood vessels dilate, blood flow increases, and the brain swells. If you bring the CO2 down with some mild hyperventilation, the vessels constrict and the brain relaxes. It's that direct and that powerful. Our choice of anesthetic agent is also a huge factor. The volatile agents we use are all cerebrovasodilators to some degree, which can raise ICP. And that is a major reason why TIVA, total intravenous anesthesia, using propofol is so popular for these cases. Propofol actually decreases cerebral blood flow and metabolism, which is exactly what we want.
And this slide right here is the grand finale. It's where we tie it all together. You can see how every single clinical action we take is a direct application of a core physiological principle. We use head-up positioning and mannitol because of the Monro-Kelly doctrine. We manage our MAP aggressively and treat hypotension to protect the cerebral perfusion pressure. We control our ventilation carefully and choose our drugs wisely to work with the brain's natural autoregulation. It's not just a list of tasks. It's a coherent, science-based strategy designed to create the best possible conditions for the surgeon while keeping our patient's brains safe.
So that wraps up our deep dive into the anesthetic management of awake craniotomy. It's a procedure that truly asks for everything we've got. Our technical skills with lines and airways, our deep understanding of physiology, and maybe most importantly, our human skills, our ability to build rapport and reassure a patient through one of the most unique experiences of their life. It's a true intersection of the art and science of our specialty. Thank you so much for joining me today.